Hello, everyone. It's our pleasure to have you today for this webinar about this important aspect of the disease, or the genetics, hereditary, and everything linked with pregnancy. And I'm Christophe Normand. I'm the chair of ENCA, that is the network of patient organizations linked with pediatric rheumatology. It's some questions that are very important for patients that will be discussed today. Savino, if you want to say a word.
I just echo you, Christophe, with we are very glad to our speaker and everyone who is joined to discuss together about this everyday question that can have always a very important perspective in people living with immunological disease. So thank you to the speakers, and thank you for all of you connecting now and then remotely.
So thank you very much. So our first speaker is Isabelle Meyts. She's professor at the Catholic University of Leuven in Belgium and head of the Clinic of Primary Immunodeficiencies at the University Hospital of Leuven. She's a pediatrician, and she will begin to explain us about the hereditary aspect and this kind of thing about these diseases. Please, Isabelle.
Thank you very much, Christophe, for the kind introduction and for inviting me to explain to you the hereditary, conditions that are primary immunodeficiency, basically. So I will actually present you several schemes that are useful for explaining an array of immunological conditions. And in fact, the model of primary immunodeficiencies is quite important in that over 480 different genetic defects have been described, and these are monogenetic defects. So I think in that way we can learn from these conditions to expand to other conditions that affect the immune system and that are at this point not really unraveled to be monogenetic. From the past years of research, we have learned that different mutations in one single gene can actually result in different modes of inheritance and different pathogenesis of the condition. So it becomes a very complex landscape also for physicians to understand what is going on. And so all the more difficult it becomes for the patients and families who are affected by these conditions to really explain or to really understand what are the implications of having an immune disorder, and especially for future children and if they are thinking about a pregnancy. Of course, much of this complexity has been brought about by the advent of next generation sequencing in 2010, 2012. Before that time, most of the knowledge we gained was by Sanger sequencing, which is a more, let's say, simple approach to sequencing than the massive sequencing we are doing these days. And by doing this, we learned a lot more about genetic mechanisms, and it makes it even more complex. And we will also see that it's very important to always think about functional validation of a variant in a gene, and that with this validation, a diagnosis can stand or fall. And this leads us to the question of precision medicine and precision treatment for patients. So to understand a little bit of genetics is quite useful for the patient, and it's also very useful to understand the future conditions if patients would debate having children. So just to give you an overview, this is the 2022 IUIS update, and you can see a massive increase in the number of conditions that have been described in the recent years. Hello?
We cannot see your screen. Very sorry to interrupt you, but we cannot see your slide. You haven't shared your screen.
That's a good remark. And now?
Yes, all good. Thank you.
Okay. So, okay. Anyway, I said what was on the slide, so you didn't miss much. So this is an overview of the complexity and the increase, especially since the years 2010, a massive increase in the number of conditions. And also, if you know something about the IUIS classification, you can see that there is a really vast increase in the conditions with immune dysregulation and autoinflammation, which nicely hints also to rheumatology and to auto-inflammatory conditions. So to continue with this, I think it's really important if we think of inheritance of a disease, of course, we need to know the genetic diagnosis. But the problem is that we also almost never know really, because in more than 70% of the patients, we never find the diagnosis of the disease at the molecular level. So there's a big underdiagnosis at the genetic level. So I think it's really important, and I always try to explain when I talk to patients that the first diagnosis is actually the clinical index of suspicion and the clinical phenotype of the patient. This can be suggestive of an error of immunity, and then we need to go further and try to find the molecular diagnosis. Level 2 can be that laboratory data support the condition of an error of immunity, which means that it is a defect that you can measure. For instance, you have too few antibodies in the blood, or you have a complement deficiency, or with more advanced, for instance, analysis, you can find that STAT1 protein is more phosphorylated than it should be. So you can measure a defect. So then you already have some laboratory or immunological phenotype of the condition. And the level 3, I would say, is the genetic diagnosis. That's a gene alteration which you find and which you can then fit with the phenotype or the presentation of the patient and the lab findings. And this requires really extensive validation for each variant. So in a way, every patient presenting to the clinic is a sort of a novel research question, because you cannot just extract or extrapolate data from literature to another variant. It's not because it's the same gene that it's the same disease. So that is really important. And this kind of fine-tuned molecular diagnosis is only available for maybe less than 30% of the patients. So that is really important to understand. So most of the time, we don't have the answer for the patient. What is the inheritance pattern? We actually often don't know. So that's the big reservation I make at the beginning of this talk. So if we go to more simple, straightforward inheritance patterns, the Mendelian inheritance patterns, so to speak, these are the 3 main genetic mechanisms that I will discuss with you. So the first one is the X-linked recessive mechanism, which, for instance, we can see in X-linked agammaglobulinemia or Bruton agammaglobulinemia, where in fact a mother or a female carrier is carrying a variant in a gene that is on the X chromosome, and then a boy in the offspring is actually affected by the condition because he inherits this variant. So this is a typical X-linked recessive mode of inheritance, where the females can carry the disease, but the boys can be ill with the disease. So you see the daughter is carrying the condition, but the son, once the condition is inherited, is actually diseased. We have to always bear in mind that even if we have a nice family tree, it can still be that there are de novo mutations. That means that a novel variant occurs in the family, despite maybe an inheritance pattern that you are suspecting, but de novo mutations occur in about 25% of the patients we are seeing. So whatever inheritance pattern you are considering, you have to keep in mind that de novo is also probable or possible. Now, if we go to the next way of inheritance, that's the autosomal dominant inheritance. And here I'm really speaking about if you have one variant in a gene and that is inherited, it leads to the disease. So whether the other gene copy carries this variant, yes or no, it doesn't matter, because one single variant is enough to cause the disease. So that is really important. So here, for instance, you see one affected gene in a parent. So when it goes to here to the gametes, actually at the conception, this embryo or this child will be affected because this variant is present. So it doesn't matter if there is one other variant that can balance it. It's enough to have this single mistake or this single variant, and you will have the disease phenotype. So that is quite straightforward, and it means in this condition, for instance, autosomal dominant congenital neutropenia by ELANA mutations, is if one parent is affected by the condition, he can pass it to the offspring in 50%, so to speak. So all patients or all kids who inherit this variant will have the condition and the disease. If we go to autosomal recessive condition, and you see here, this is a consanguinity trait, but of course, autosomal recessive doesn't only occur in consanguineous families, but it is more prevalent in consanguineous populations and families. In this case, so both the father and the mother, so to speak, carry one variant on one of the alleles, and in the embryos, they can come together, and this is in 1 in 4 of the conditions, statistically speaking. And so 1 in 4 of the children will be affected by the condition because they will inherit one variant from, for instance, the father and another variant from the mother. So here you can see that 2 of the children in the ideal statistical world would have a carrier condition, whereas 1 child would be unaffected. This is all in the perfect world of statistics and mathematics, which is of course not the case in biology and in medicine. So that is also very important. So what we now saw was actually Mendelian inheritance, where you can see that if you have the variant or the trait, the genetic trait, you will have the disease. Yeah. So in autosomal dominant, you have 1 variant, you have the disease. In autosomal recessive, you have the 2 variants, you have the disease, and X recessive the same. However, in autosomal dominant conditions, and especially in gain of function conditions, it can be that individuals who carry the variants express the disease phenotype, but not for all. Yeah, so it can be, for instance, that you have the variant, but that you are not sick clinically. It can be that even the immunological phenotype is present, but you're still not sick. So why this happens is really not well understood at this point. It can be that the rest of the genetic background of the individual is different, and so that the disease is not presenting itself. It could also have to do with the environment, which poses differences on the presentation. But it's of course very difficult to counsel in any of these conditions because you cannot predict if the child will be sick, not even if this child is carrying the same mutation as the father or mother who are sick with the disease, or vice versa. So you can have the situation where a parent is carrying a gene variant that would lead to, for instance, Stat3 gain of function disease, but is not sick, whereas the child who is born from this parent carries the gene, can be sick with the disease. So it's very complex, and it's very complex to counsel these patients. So if we have a look at the inheritance patterns in the inborn errors of immunity group, you can see here these are autosomal recessive diseases. These were all found by Sanger sequencing. You can see that this is the addition by next generation sequencing. So all in blue is autosomal recessive. You can see it's the largest group, yeah. Whereas X-linked is a smaller group, and an even smaller group are the autosomal dominant conditions. But these are gaining field, and in the next update there will be more autosomal dominant conditions again. So another remark I want to make, so in the easy inheritance pattern that I discussed with you about X-linked disease, the case of Bruton agammaglobulinemia, it is quite straightforward that the carriers, the female carriers of the variant, are not sick. The problem is that increasing knowledge in this field shows us that carriers of these X-linked diseases can display disease characteristics. For instance, it's well described for XCGD, so chronic granulomatous disease. It's very clear that depending on the level of silencing of the healthy X chromosome, you can be sick as a woman with this condition. And the same, for instance, for XIAP deficiency. And probably this is more important than we know up till now, because several other papers and reports are popping up showing us that X-linked disease in carriers can also lead to a clinically relevant condition that needs treatment, even up to stem cell transplantation for XCGD. So that is quite important also, and something to keep in mind when counseling. So it's not just so easy to say, okay, it's a girl, she will not be affected. We are not so sure about this anymore. Complex mechanisms are even more difficult to explain. There are things like germline mosaicism, where you can have 2 children in a family tree where the father and the mother are not affected, but the 2 children are. And this makes you think of an autosomal dominant pattern. And actually, in some of these conditions, it has been found that the germline carried a variant which was not found in the blood of the father and mother, but only in the germline. So only, for instance, in a sperm cell or in an ovocyte. So that's really very important to realize that this is happening. And also sometimes we find a de novo germline mutation, which is even more difficult to start and think about. I also want to highlight this. This is not strictly speaking inheritable, but somatic mosaicism is popping up as a really important cause of immunodeficiency or immune disease. For instance, VAXA syndrome, which we all know well, is caused by somatic mutations. So only a fraction of cells will carry the variant. And actually a nice study by the group of Barcelona showed that this kind of mosaicism played a role in up to 25% of the families they had studied and who suffered from inheritable conditions of the immune system. So I think it's really a field that needs more investigation, and also it's only since recently that we are able to sequence this well and this deep to really find convincing reads that show us that there is mosaicism, because with Sanger sequencing it was not so easy to find those mosaicism fields. And then to make it even more difficult, there's oligenic and multigenic. There are several reports in the literature where one gene is not enough to have the disease, you need 2 genes to have the disease. So that makes it even more difficult to understand where you go to and what will happen if you have children and how they will be affected. And then there is the epigenetic inheritance, the epigenetic influences, if genes are transcribed, yes or no, if they are altered at the DNA methylation level, if the promoter allows the gene to be transcribed to a protein. So it makes it all very, very difficult to come up with an easy explanation for several of the patients with inborn errors of immunity. So I'm going to give you a final view of mine on counseling, which was the initial topic of this lecture, is counseling. But I'm not a counselor, I'm not a geneticist, I'm a PID physician. And I think counseling is always a bit different from the perspective. And I think here it's really crucial to balance the knowledge we have on the condition, on the molecular diagnosis if we know it, but also on the penetrance and the morbidity and the mortality that comes with this condition. Because it's not only about mortality, it's also morbidity. And to have a lifelong treatment, to have fatigue, to have all the musculoskeletal symptoms, the infections, etc. It's about quality of life as well, and also about expected advances in therapy. So every family is different and every disease is different. So it makes it really hard to give, to really give a good advice to parents who seek advice. And as I said, classic statistics don't apply to experiments with limited N value that will. And I said in the beginning that we've had patients where, autosomal recessive condition just repeated 4 times in 4 children, which is of course the worst you can ever think about. And you can always talk to parents, but you cannot really decide for them. Also very important is that mild disease in one sibling can obscure the counseling. For instance, okay, but this boy already has that condition, everything is fine, so the next will also be fine. You don't know. For instance, Bruton can be a disease that is relatively mild and just needs some immunoglobulin therapy. However, depending on the exposome and the bacteria and the viruses you come across with, this can totally change the course and leads to a very, very difficult to treat condition with a lot of comorbidities. So I think it's a difficult mixture of medical knowledge, ethics, genetics, but also some health economic perspectives, and never to forget about the quality of life of patients affected by immune conditions. And I think that's about what I wanted to say for my part. Thank you.
Thank you very much. Very interesting, and I guess we'll have several questions after. Savino, if you want to introduce our next speaker.
Sure. So thank you, Isabelle. And going from one part of the counseling to the other part, and we follow, and it's our personal and professional pleasure to have here with us Laura Andreoli. She's Associate Professor of Rheumatology at the University of Brescia, Italy. She's a consultant rheumatologist at the Rheumatology and Clinical Immunology at Spedali Civili of Brescia, and the unit is also a member of the ERN-RITA. So thank you, Laura, for sharing thoughts and ideas with us.
Thanks, Savino, for this kind introduction, and thank you for the invitation. So it's really a pleasure to be here tonight and discuss with you about the management of high-risk pregnancy. So just to make sure, can you see my screen? Yeah.
Yes, we can, Laura. Thank you.
Yes. Okay. Thank you. So these are my disclosures, but actually I would say the most important disclosure for tonight is that I'm a rheumatologist. And why am I speaking about high-risk pregnancies? Because I had this chance and fortune in my career to join the group of rheumatologists and clinical immunologists in Brescia since the very beginning. And since the 80s, there's a joint pregnancy clinic there for the management of women with autoimmune rheumatic diseases during pregnancy. So I had the chance to work very closely with obstetricians who are dedicated to the management of high-risk pregnancies. So I actually would like to use some examples borrowed from rheumatology, which can actually apply to several inflammatory and autoimmune diseases. So even if these are concepts that are relevant also for the diseases included in the ERN-RITA. So when we think about reproductive health in people living with chronic diseases, we recognize several factors that can actually impair the reproductive capacity of these people. And of course, there are disease-related factors that can have a direct impact on how the hormones work, how the person feels, and how actually liaises with other people. So this actually has an impact on the psychological status of the person, also on the sexual function. So these factors can really reduce the chances for a conception. And then there are several drugs that we use in rheumatology in treating autoimmune diseases that can have some kind of impact on both fertility, or they cannot be used during pregnancy because they may induce malformations. And I'm referring mostly to methotrexate and mycophenolate mofetil, which are drugs that are used quite frequently in rheumatic diseases. So what does this impact on reproductive health turn into in real life? Well, we see in our patients that they had a reduced family size. So it means that women had fewer children than they originally planned. And so this is due to several reasons, and they actually may refer to factors before, during, and after pregnancy. And you see, there is actually a fear of passing the condition on to the child, and a fear during pregnancy to harm the baby by taking medications. And then when the baby is born, there are actually concerns about how and when to breastfeed and how to carry on and cope with parenthood while living with a chronic disease. So these are all factors that, you know, patients would like us as clinicians to address during our conversations in the clinic. But you see, there are many topics that we need to address, and it's not always easy for a rheumatologist, internal medicine doctor, or whatever specialist who is in charge of your autoimmune disease to go over. So that's why we need a multidisciplinary approach. We really need to pull together different competencies and allow the most frequently asked question of our patients to be properly answered. And let's start by saying what's the definition of a high-risk pregnancy, because this is a terminology that we can find in any chronic condition, so it just doesn't apply to autoimmune diseases. So high risk means that there is an increased likelihood for complication during that pregnancy. And that is due to the presence of specific risk factors. So here in this figure, you can see some of these factors, and some might be, you know, general, like being an older mother is something not related to your disease, or maybe actually it could be because maybe your clinicians have told you, you know, you should better wait for having a pregnancy. We need to wait for your disease to be more stable. So, you know, it may actually happen that ladies with autoimmune diseases get the green light for pregnancy later than their healthy peers. And then there are other factors that can be related to the disease itself. And yeah, you can see that hypertension, diabetes, thyroid disease are all health conditions that can really add some risk to the pregnancy itself. Then there is an emerging problem, which is obesity. So it's something that is growing in the general population. And yeah, we must be aware of the implications of that during pregnancy. So definitely lifestyle is important in general in autoimmune diseases, but especially if you are a woman of childbearing age, then healthy lifestyle is definitely of fundamental importance in order to allow and to pave the way to a successful pregnancy. And sometimes we see patients who already had complications like preeclampsia. So such a hypertensive disorder of pregnancy can be recurrent. So we need to put in place preventative measures to reduce the risk of recurrence. And how do we do this? So we ask the patient to come in to discuss pregnancy beforehand. So the so-called preconception counseling. We really need to hear to our patients, to their preferences, to their plans, and to come up with a shared decision making. So the patient will need to know which drug must be taken during pregnancy, which drugs must be added as preventative treatment as soon as the pregnancy test turns positive. So it's really a teamwork together with obstetricians and gynecologists to reach the best situation to allow pregnancy. So, but I acknowledge that high-risk pregnancy is actually a term which might be a little bit scary. So it's good to underline that this is an umbrella term. So we refer to high-risk pregnancies to those pregnancies which actually need closer monitoring and, you know, a very particular and careful prenatal care. But it doesn't mean that something will go wrong for sure. Well, actually, we are working against that. So it means that, you know, we might have more challenges, but, you know, this doesn't exclude that everything will be fine in the end. So, and how do we manage high-risk pregnancies? Well, again, multidisciplinary team is important. And we need to inform the patient during preconception counseling that she will actually have more visits during pregnancy. She will need to come to the hospital more times to have additional blood tests, additional fetal ultrasound scans. So this is something that they need to know because, of course, they need to get organized with their job and, you know, whatever activity in their lives. And another very important topic is the discussion around medications. So we must address a very important concept that we need to keep disease under control, because a disease flare, high disease activity, is bad for the fetus. So we need to come up with a personalized treatment plan. And then, of course, during pregnancy, the obstetricians will be in charge of checking on fetal well-being. So we must make sure that the fetus grows regularly and that the fetus doesn't stop growing or doesn't slow down their growth. Otherwise, we need to maybe decide for an early delivery. So it's actually very crucial to decide the best timing for delivery. So when the baby is maybe, you know, is gonna be better outside the womb than actually inside the maternal womb. So these are all things that we want to address during preconception counseling so that each woman knows about their own pathway. And what are the obstetricians looking for particularly? And this applies to autoimmune and inflammatory diseases cross-sectionally. We are looking for placental insufficiency because we know that inflammation and specific autoantibodies may actually impair the development of the placenta, and this, you know, not properly developed placenta doesn't actually work properly, and then the outcome will be that the fetus doesn't grow correctly. So you can see here in the figure, so the placenta is smaller and the baby is also smaller, which is a condition called intrauterine growth restriction. So what is the most awful consequence of this defect in growth? Well, it might happen that if the placenta is really, you know, struggling, it might stop working very early in the pregnancy course. And so the baby might actually end up in a stillbirth, so a fetal intrauterine death. So we as a multidisciplinary team are working together to prevent these complications by giving the right medications. For instance, you will hear many women with autoimmune diseases taking low-dose aspirin, because this is actually a very good medication to prevent preeclampsia and to help the placenta, this big sponge full of blood, growing correctly so that the nutrients and the oxygens are delivered to the fetus correctly. And so getting back to rheumatology, this is an example of what we do with rheumatic patients. So our risk stratification takes into account the point of view of the rheumatologist and the point of view of the obstetrician. And you see, we go through this checklist and then we say, okay, you have a low risk, a moderate risk, or high risk for pregnancy complications. And you can see here in the high risk box, we have something that can apply to any disease, which is active disease. Whatever your disease is, as long as it is active, that is bad for pregnancy. And then organ involvement, I mean, pregnancy is such a huge stress test for the woman's body. And so if your lungs, your heart, your kidneys don't work properly, then of course their function might get worse because of pregnancy. And then you see there is also a focus on medications. As I said before, this is really the most critical topic in our conversation. And yeah, just to let you hear it from the patient voice, why is it so difficult to manage medications during pregnancy? Well, you see, these women from Australia living with rheumatoid arthritis, they say, well, I find it frustrating when the pharmacist doesn't want to give me the drugs that my rheumatologist prescribed. Or they say it's really a struggle because I don't want to harm my baby, but I do trust my doctor. So what shall I do? And the struggle is even bigger when specialists have different opinions. So the rheumatologist says one thing and the obstetrician says another thing. So this is something that we really want to avoid, because pregnancy is a delicate period and we want our patient to go through it in the best way possible. And so this is actually why scientific societies came up with recommendations to give a guideline to physicians in order to manage the conversation around pregnancy in the best way. And you see here, these are overarching principles regarding the use of drugs during pregnancy. And the point is about balancing the risk of maternal flares against the possible harm to the baby. So it's always a risk-benefit assessment. So please keep in mind that something that applies to one patient might not apply to another patient. So it's really an individualized process. So despite all the efforts, there are still many things to be done. And this survey ran by the ERN-RITA was inspiring, because they actually asked the patients what is still lacking in the management of pregnancy. And you see, they referred about the fragmentation of cares, the lack of awareness, so many HCPs don't really know much about pregnancy. And actually, there is not a holistic management, because pregnancy is such an emotional period, and we as doctors don't have time, don't have preparation, we don't feel confident in addressing all the aspects. But our patients actually would love to be cared in a holistic way. So What can we do more? Well, yes, there is something that we can do, and I can show you the experience we did in Italy within the Italian Society for Rheumatology. These leaflets were very useful to open the conversation, not only with the patient, but also with the family. And you can find also very nice resources here on the University of Duke web page in the US. So these are sheets that can actually be downloaded by physicians and used as checklist while seeing patients. And I love this infographic because it really says the most important concept. So a healthy mom will likely have a healthy baby. A sick mom would likely have a sick baby. So if we need medications which are compatible with pregnancy, so let's use them, because if they make the mom feeling good, then the baby will be also good. And you see there are other resources by the American College of Rheumatology. And yeah, so it's just a matter of enhancing the conversation around these topics. So to me, the ideal setting would be to have a setting which is privileged, to have time to speak, actually to listen to our patients and to speak with our patients. And now today we have gone over pregnancy, but of course it's also the other way around. Whenever a patient doesn't want a pregnancy, we need to address contraception. So it's really a process of shared decision making. And as EULAR, we are working on these topics, and I have the honor and privilege to co-chair the study group on reproductive health and family planning together with Karen Schreiber, who is based in Denmark. And we are gonna run our annual meeting during the EULAR Congress in June. And if you are in Vienna, so please come by and join the meeting. Or if you cannot come to Vienna, please write to myself and Karen, and we will provide you with the link for the remote broadcast of the meeting. So, and with this, I thank you, and happy to take any questions.
So thank you very much. It was really, really interesting. It's yeah, very important for the everyday life of the people. So it makes it very valuable. I don't know if there is question from the audience, but maybe first question that maybe to Isabelle, but maybe also to you, Laura. We are in the frame of ERN-RITA, and we have the patients everywhere in Europe. So is this counseling, this genetic test available everywhere in Europe, or there is still some centers that are referenced in some countries, and you don't have the same access to everything depending of where you are?
Well, I think indeed access to this next generation sequencing for diagnosis is not uniformly available in the EU, and there are still several states where it's not easy to have a gene panel performed. Having said that, with S2 documents or with the necessary, I mean, there are options to do it in other states and to get it done, but of course you need the willingness of the physician also to be able to help and to find a way to a lab that can do the testing. But overall, I think, to be honest, we're in a better condition than in the United States, for instance, where it's very difficult to have a genetic testing performed with next generation sequencing, where it really depends on the insurance willing to pay for the test. So I think by and large, I think it's possible to have it done in an accredited way in a neighboring country. And I think the ERN plays a big role in this kind of cross-border facilities.
Thank you.
I don't think there is no question yet in the chat. So if I can take the advantages of the microphone, I would love to share some thoughts and use Laura's expertise, but also Isabelle, to share one of the problems that often we share in clinic, which is the compatibility of drug and medication when planning pregnancy. So if Laura, if you can share some of your tips, how we can share the proper counseling and information to ensure that some medication can be used during pregnancy and also during lactation, because it's often not spoken enough.
Yeah, thanks for your comment, Savi. So it's really a crucial topic because there is a cultural background, I would say, in most of the countries about the fact that no medications should be taken during pregnancy. So many women come to our pregnancy clinic and sometimes they don't know that is actually not only possible, but needed. And, you know, we talk with them, we go through all the explanations, and they get convinced that it's good to take medications, of course, those which are compatible. But then they turn back to their family and they say, oh no, you shouldn't take any drug during pregnancy. Who told you that? So it's really a matter of having the information delivered in the best way for the patient and for family. And another concept that is quite relevant is that the very forbidden drugs are very few. So those which can induce malformations are very few, and all the doctors know them. So it's really unlikely that a patient will be put on a medication without telling her, okay, but you shouldn't get pregnant. So, but there are actually many other drugs who are, possibly compatible with pregnancy, but still we don't give a green light because we don't have enough data. There's still no evidence, not enough evidence to say, okay, we can do it. But this doesn't mean that we can propose the use of such drugs in selected cases. So, I mean, if we have a woman who has a really active disease during pregnancy and she needs that new biologic treatment to control her disease, I mean, we can come up with shared decision-making and give that drug during pregnancy despite very few data being available. So everything takes a lot of time to be discussed, but it's just to offer the best that we can offer to our patients.
Okay, thanks. In the community of patients in RITA, in the frame, we have several diseases, kind of diseases that are not really the same. And so the chance to have a normal pregnancy or not high-risk pregnancy, I guess, is depending on the kind of disease and how many % of either high-risk or no high-risk pregnancies do you have in general? Is it, I would say, 50-50, or it really depends on some diseases?
Yeah, completely true. So each disease might be different from another one. So I will say that the terminology high-risk pregnancy applies to all the pregnancies, because that will directly turn those women to a high-risk track. So actually they will get more monitoring during pregnancy. But then it should be made clear to the single patient, so you are not at very high risk of complications, so your risk might be very little, but still we want you to have additional tests and additional ultrasounds during pregnancy. And I think it's really a matter of preparing the pregnancy. So whenever pregnancy is planned, medications are in place, and there are no concomitant risk factors, then the outcomes are pretty much in line with the general obstetric population. We still see an increased risk of preeclampsia, hypertensive disorders, preterm delivery, but definitely the outcomes have hugely improved over the decades because of this multidisciplinary management, planning, and treatment during pregnancy.
Thanks. Thanks a lot. Yeah, it's yeah, and every case is different. Every patient, every family is different. So that's also something that we experience ourselves quite often. I don't know if there is other questions.
If there is no other question, I might ask another practical tips from both Isabelle and Laura, again, to involve in the decision sharing both sides of the discussion. So do you have any practical tips when discussing with your patient? Like, do you suggest to prepare question in advance? Do you ask them to come back to you after a couple of weeks if they have any further? I know this is an ideal world and time is always a constraint, but let's hope we can reach an ideal world. Which are your practical tips in order to make the conversation as smooth as we can?
Well, maybe I can start. Of course, I'm a pediatrician, so the questions asked to me are usually not really about the pregnancy risks themselves, but rather for the children. But as you say, what I usually do is that I ask parents to make a list of questions before they come to see me, and also that we rediscuss with another, like that they keep a diary or that they keep notes so that they can ask more questions as after we speak. And usually this really helps to have all the questions asked in a sort of organized way, so that people and that patients really feel listened to, and that we have done the best to answer questions. And sometimes this involves also that I reach out, for instance, to adult or internal medicine physicians, and to, for instance, the gynecologist and the geneticist, to really have a multidisciplinary answer to the questions of the parents. We don't have at this point the beautiful multidisciplinary clinics like you are discussing, Laura, but I'm really impressed how you are going about these high risk or risky, at least difficult pregnancy questions. And I think it's really very interesting to see this model, and it's definitely probably in many other areas and a very high need. So I think it's really beautiful to be able to do that in that way. But honestly, we have a very low threshold for being accessible to patients. That's also, I think, typical for our conditions, for the conditions and the patients we are providing care for. I think we are very easily accessible. It's not like that people have to go through very difficult hurdles to ask additional questions after we've seen them. And I think rediscussing, we have flyers about several conditions, so that they can read and then have more questions, etc. So I hope this answers the questions a little bit.
Yeah, thanks, Isabelle. I may actually echo you in the sense that patients really benefit from written material. So it's good to have flyers in the office and to share this material with them and ask them to come back or to send an email or to reach out by telephone if there are any burning questions when they go home and they, you know, review the material. Well, what we suggest to our patients is to come with their partner, of course, because it's good to run the counseling to the couple. And whenever it's possible, it's good to negotiate with the hospital more time for this pregnancy clinic. So we actually have more time for preconception counseling than for regular visits. So it's really a matter of having you know, quiet space where all the questions can be addressed. And then, of course, it's good to reinforce the counseling. So sometimes when I feel that the couple didn't, you know, we didn't have enough time to cover all the issues, or they were, you know, in doubt, then I invite them to come again, maybe 1 month later, 2 months later. So I would say it's really a process of sitting next to your patients and talk a lot and yeah, just help them in answering their questions.
Thank you so much. Very useful tips.
So I guess we come to the end. Thank you very much. In the name of the patients and the patient communities in RITA, thank you very much, because it's burning topics for all the families, and it's sometimes difficult to discuss with the medical doctor about some topics, and yeah, to have some ideas, it's very, very interesting. So thank you very much. I hope it will be useful for all the patients and the people participating and listening. So thanks again. And yeah, Savino, if you want to say a word.
No, just thank you again, Isabelle and Laura, for the amazing sharing and expertise and time. Thank you. Thank you once more.
Thank you.
Thank you. Bye-bye.
Bye-bye.